hope everybody's having a informative and productive day thus far. And we're going to move into what we're calling our town hall meeting segments for this afternoon. So several of you have either electronically or in writing submitted questions. Is there anybody who's holding a card right now that you would like to get? Let's speak now if ever hold your piece. I'll go with what we've got. Otherwise, you will also have, we'll have microphones working the room, and if you have a question that you would like to raise from the floor, we encourage you to do that as well. I will ask you to please wait for the microphone to come to you because we are live streaming the presentation, and so you cannot be heard if you are not electronically enhanced. So, for our town meeting this afternoon, my name is Brian Mack. I manage marketing and communications for Great Lakes Health Connect, and I'll be moderating for the next half hour, 40 minutes or so. You have all already met Doug, our executive director. We have two of our leadership team who are, one is at a conference and the other is on vacation, and so when we have two senior leadership people out, it takes 2 people per person to backfill for that individual. So, so Chris Ford and Mary Graham are here for George Bosniak, who is our director of business development, and then Julie Klossing is also away on vacation, and so Steve Speaker and Adam G are both representing for her. And then Craig is also here, who is the director of, I'm going to get that wrong, and I'll let them introduce themselves.
Technology Services
Thank
Support.
You. Gosh, I wanted to say operations, that wasn't right. Yeah, if you would like to, briefly just introduce yourselves and what your role is, and we'll go from there.
Doug Hicksman, Executive Director for the organization, so I get to do a little of everything.
Chris Ford, Account Manager in Business Development.
Steve Speaker, or Manager of Solution Support.
Mary Graham, Manager for Community Engagement.
Craig Meyer, Technology Services and Support, handling infrastructure, desktop security, along with my cohort Lisa, who's out there. I'm going to point her out and make her feel uncomfortable. But and she won't come on.
Adam G. I'm the manager of our project management team.
Okay, so jumping right in, again, we took a variety of questions from a variety of sources. We had some invitations that were sent out, and so had some of those things submitted electronically as well as those that have been submitted in writing throughout the day today. Doug, we're going to get the big one out of the way right off the bat. That is one that I know that our implementation consultants get on a very regular basis, which is how would you characterize the relationship, Great Lakes Health Connect's relationship between those other health information exchanges in the state of Michigan, and how does that differ from MyHIN, the Michigan Health Information Network?
Okay, so GLHC was founded by the provider organizations to serve certain needs, and so we have become over time statewide. So we have now 129 hospitals, cover 85% of the acute care beds in the state, pretty much everything below the bridge, although there's a couple hospitals up there, and then 4,000 connected locations in some way or another. We are funded and sustained exclusively by our participants and solving problems for them in ways that entice them to want to pay us to help solve those problems for them. So we're not federally funded, we're not state funded, we are funded by our participants, as our business model. So, we were born to solve these problems. MyHIN was created back in the day with the state and operational plan to say there's going to be multiple of these HIE things in the state. So there needs to be something at the state level to kind of coordinate their activities. And then also maybe be a front door as it's evolved to the state itself. So all the immunizations, all the reportable labs, everything kind of coming in and out of the state goes through MyHIN. That's kind of their chosen vehicle for single doorway into their systems. So we interact a great deal with MyHIN, their use cases, those that I mentioned, as well as others that are in the works. Nobody has done more with them to successfully implement the use cases that all of you really, we're working on your behalf to make sure we get you connected in a way that either meets your meaningful use requirements, that sort of thing. Really, I think one of the finer points is if you talk about what is a health information exchange, if the way I view it, it's an organization that's in the business, first and foremost and primarily for doing what we're doing in connecting a community together. On that definition, I'd say GLHC is the only one in the state. Health information exchange is a verb, and data is exchanged, and there are lots of organizations that do that with other partners as kind of an aside. They're either providers who do it, or they're health plans that do it. There are other organizations that do it. GLHC is the only one, as I understand it and spend a lot of time up there, is the only organization in the state that was created specifically and primarily for linking the healthcare system, all components, multi-vendor, multi-stakeholder, all pieces and parts. So a little bit longer answer to the question, but essentially MyHIN has use cases that are defined through the state or through Blue Cross Blue Shield sorts of requirements that the providers need to meet. We are deeply engaged and regularly engaged with them to make those things happen. But what we do is on the ground, which is not where MyHIN is. So we're in the community at a very local level, like we're talking about here, and then we interact with them at a state level relative to how things need to be shared in and through their through the state or other use cases that they have.
Thanks. Craig, this is a security question that's going directed toward you. That there have been, well, it seems like virtually every day, but very recently a couple of significant stories about security breaches involving health data and health information. Can you talk a little bit about what GLHC is doing to protect the PHI that we manage?
Sure. So I think when we talk about security and overall just network safety and patient health information safety, it's really looking at it from a multi-tiered approach. I think what we try to do within Great Lakes Health Connect is truly to understand that we need to really obviously handle that data in a specific way, not let easy access to it, being able to secure our internal network, but also our laptops and our desktops as well. I think you see, too, in a lot of different healthcare news, breaches of information based on malware, antivirus issues, folks just surfing, bringing, personal laptops in from home and things like that. Part of that, too, is if folks were able to sit in the earlier session with Nate Steed, is really to understand, and implement policies and procedures within your own environment. And obviously, Great Lakes has been doing that and continues to modify and tweak those policies and procedures internally. We're looking at or pursuing iTrust certification as well, an industry standard that helps us kind of do a checklist to ensure that our data is private and policies and procedures are in place, to ensure that data is kept safe from outside use.
Great, thanks. Here's one that's actually, it's actually directed toward me. The question is, does GLHC provide marketing materials or other resources to help us being practices as outpatient clinical care providers, physician groups or other referral sources, and to join and to use GLHC? And the answer to that question is yes. I've heard it referenced a couple of times in different breakout sessions earlier today, referring folks back to our website. So there's a wealth of opportunity there in terms of resources, collateral, all of those kinds of things. One of the things that we do however, that is not necessarily as well known is that the marketing team, which really consists of Emma Lilly and myself, will regularly partner with practices to create custom materials if that's something that is helpful to you. And the best way to go about doing that is you can certainly reach out to me directly or go to your implementation consultant and ask them about what the best way is to get something like that done. They'll in turn get in touch with me. We can co-brand materials. We have, as I said, a wealth of existing collateral materials that are in place today, and we're very willing to do whatever we can to help build your network of connected communities wherever you happen to be practicing. So I encourage you to reach out to us and let us know how we can help.
Just something to add, Brian. One of the most powerful things in this journey that I think working with Steve from day one on some of the referral stuff that many of you folks I think are using, one of the biggest pieces I took away was our spiel, our marketing, our, hey, sign up for this, this is what it does, it's really cool. Not as effective as you talking to a group that's not on it, that you think needs it because of everything that's going on between both of you. Relationship. And quite frankly, a lot of what we do, that relationship, peer-to-peer or industry-to-industry or whatever, far more effective than us trying to reach out on your behalf. I say that, A, in itself, but B, tag teaming with this team, the marketing perspective of putting documents together that have multilinguals or whatever, logos, but also put something together. Recently, one of the ICs, Brian Bullock, is in here somewhere, and he and I went down to Monroe and met with the CMH down there, and the CMH said, I want to get a group of people in the room. I want them to be offices, I want them to be primary, specialists, I want people from Ohio here. They came up with that idea. To me, that is effective. Talk about that patient at the end of the day getting looked after. Didn't expect that when we showed up, but in terms of that mind of let's try to do something together, or even branding on your own that you may need some support in, it's just really effective.
And we're not going to let that go just yet, because as in the role of community engagement, the implementation consultants, all of whom are here today, are located throughout the state, and they can work with you as a PO, they can work with you as a practice. We have materials that you as a practice could send to your peer group and say, hey, we're on this platform, we'd really like to see you on this platform as well. It will expedite our relationship and do better transitions of care for our patients. We can provide that documentation to you as a practice. We can also do it to you as a PO, so as an organization, and we can also co-brand with you. As Brian mentioned, we have a partner on the east side of the state, took our materials and surprised us with the quality of what a one-page document that they are distributing in order to link behavioral health with primary care. Because that is their passion and that's their market. They are a behavioral health organization and they want the primary care to join them in the referral network. So yes, we're happy to help you, and we have tools that can get you started. We have people that can work with you, and we're happy to see you go on this journey with us.
Great, thanks. That for those of us who are customer facing, we get the privilege of spending a lot of time one-on-one with you. Many, and I've heard a couple of these comments today, many of you know us by a voice over the phone or by the conference call that you happen to be on and updating things. Many of our solution specialists and project managers work largely over the phone with our clients, and so this is a terrific opportunity for us to be face-to-face. Adam's one of those people as our manager of project management. And Adam, the question that was raised is what kinds of new initiatives or projects is GLHC undertaking that you think are particularly compelling for enhancing the quality of care initiative?
Yeah. One thing that we've done over the last couple of years is immunization history, and that's getting the immunization sent up to the state of Michigan. Great opportunity, so some efficiencies there, but it wasn't really anything in it for the offices. What we're coming about now is the immunization query, is having that, the data's all up there now, and now offices and hospitals can now query the data and get it back natively in their EMR so they can know what data's been done for the patient, what's already been done, what's forecasted for immunizations. So that is one of the solutions that's really just starting to take off. That is a big win, I think, for offices and for the end user, and just a lot of time savings and a lot of that good quality data right in their hands that's useful.
Awesome, thank you.
Hey, I'm gonna throw it in here. You want to talk about single sign-on and where we have that and kind of how that is helping the overall flow and getting into, Viper record.
Yeah, single sign-on. So we have the Viper tool, and that's a great opportunity for someone. If they don't have an EMR, they can log into it. But really, our goal is that they allow them to natively get from their EMR, pull the information out of Viper. And single sign-on allows you within your Epic, within your Cerner, within your other EMR system, to, when you're already looking at a patient, to then pull the data from Viper without having to go to a secondary system and log in and pull the data. So it's using that, the demographics in that patient, as well, it kind of queries Viper, pulls the information back so it's natively viewable within your EMR. So that's, you always hear about penalty clicks for physicians. It's saving physicians and other clinicians a lot of penalty clicks because the data is, viewable right in their EMR.
Many of you may or may not be aware that most of us on staff at GLHC come from a variety of different backgrounds, but largely from healthcare backgrounds in one way or another. Steve Speaker, who manages our solution support team, is a social worker by training and spent many years working on the acute care side of the business is in social work. Steve, could you give us your perspective? He's also one of the very early staff team members, so not number 5 or 6 or something like that. From your care coordination perspective, could you speak to the solutions that you have found, and particularly recently, that are most significantly contributing to the quality of care, to helping advance quality of care in Michigan? What do you think that those things would be?
A couple of them. One is with the referral application. Many of you out there are currently using. That's been going on for now actually 5.5 years, but it still continues to grow and make a significant impact. Many that I talk with, when have said we can't live without that now within the way it's in our workflow. But just one example along that line, and this was a few years ago, but it still impacts today. I was in Port Huron at an ENT specialist, and as I was talking with them about it, just my mindset at that point was within their community, and they said, "Oh, you have ENT consultants in Grand Rapids?" It's like, yes, they're on there, and they go, "Well, we make referrals to Grand Rapids because of a specific specialist." So to realize that referral application is truly statewide, but it's grown more than just from primary care to specialty. We now have food banks on there. We have different health agencies. So it's really one of those, as you think about within your own community, of any time when you're having to transfer that information, it's not just a referral, but it's a way of sharing that information without phoning or faxing. To be able to utilize it, it continues to grow. We now have over 1,200 sites throughout the state that are utilizing it. And it's you folks, not us, that have made over 109,000 referrals this year alone. So it's phenomenal when you think about it. It's over 58 counties as well. So that one, I think, from a community perspective on being able to share, even with behavioral health and medical, I know that there's the, all the CFR 42 and all that fun stuff we have to deal with, but yet it's still a way to be able to find ways to share that information is amazing. The other one too, I think that, and again, from an ER social work perspective, that aspect of what Viper can do is an amazing, incredible tool. I just wish it was there when I was in the ER. Thank you, they had to wait till I quit, and then we decided to get it out there. But it's a phenomenal tool, as Dr. Pola was saying, that is, to me, made just a valuable asset to any practice, any hospital, instead of having to request those records back and forth.
And just in follow-up, in my personal background prior to getting into health technology was in residential senior living, long-term care, post-acute, basically all of those geriatric services. Steve, one of the things that folks might not know as much about, that one of the things that GLHC is doing is I wonder if you could speak to the Patient Care Documents Initiative that you really head up and tell us a little bit more about that as well.
So with Viper, a couple years ago, as we were looking at having all that medical information into one place, we began to realize that if you're going to go out and view that information, again, from a ER social work perspective, but broader than that, to have those patients at that time of need have their advanced care directive instead of in their glove compartment, in the lockbox, in their freezer, with a relative somewhere else, to have that sit alongside that medical record at that moment, at that time of need, is very powerful. Just real quick, another story that I hope I never hear again, is that there was just recently, a patient was at one of the hospitals unconscious, and they knew they had an advanced care directive. It was at another hospital. When they asked the hospital for that information, and I get it with HIPAA, I understand it, but they couldn't release that because the patient couldn't sign. Well, they're unconscious, it's like, come on. And again, I get it, but if that advanced care directive had been sitting in Viper instead, that patient's wishes could be honored and they would have that information right then and there. So we worked with a developer to have a way of, it's a simple two-step process through a web portal of being able to add patient demographic information and upload that advanced care directive, durable power of attorney even, living will, organ donation, DNR, any of those documents that are important for that patient, to have those sit alongside the record. We then had a pediatrician who's very passionate about her asthma kids. And she said, if you're going to do that, then I want my action plans. I want my asthma action plans there so when they show up in that ER, they know what our wishes, our plan is. So we expanded it to also include asthma, diabetes, cardiovascular. So any of those action plans that you have in your offices or care plans, those also can then sit along that record instead of, other medical professionals or the hospitals not knowing those wishes or knowing those care plans, etc. Those sit alongside the record as well. There's no cost for it. It's a great community service. But really on those, if you have those advanced care directives sitting in your records, please let us know. We'd love to have those get uploaded as well.
Thanks, Steve. Chris, we've spent a lot of time today talking about acute care and ambulatory care, primary and specialty. Springboarding off of Steve's comments just then, this is going to be the most poorly rehearsed hint in the history of the world. But can you tell us a little bit about some of the exciting business opportunities that we have in terms of growing our range of services across the continuum of care?
You want to know? So, Adam spoke a little bit to some of the opportunities and some of the new things. We're really diving into the skilled nursing, home health, assisted living industry. We're really trying to, there are going to be a lot of tasks of delivering information to the state for these groups. We've been engaged with Leading Age of Michigan and working with them specifically on how can we get their customers, what's the great word, implemented, if you will. But all these other conversations we've had about relationship, about actually talking and consulting, one of the things I love best about Doug is when you go see someone or talk to someone, whether it's a hospital, doctor's office, community program, CMH, listen first. And I think that's our key and first and foremost thing that we do best and that we really need to do more of anyways. So in answering your question, when it comes to some of the things we've done traditionally well, the referrals application, there are things we would like to internally uplift on that application to help that user because we all know that Sometimes the cloud is a little bit easier than having to host things or have to be dependent on my IT service vendor, which is good, but some things that we can enhance for you. So I know that there's plans for some of those types of things. Our Viper application, getting it into the EMRs, getting immunizations back. So the immunization query is definitely one of the biggest things we really want folks. You live in your EMR, so we want to keep you there as much as possible. In terms of other things, we have, I mentioned the skilled nursing and home health, being able to report the MDS for the skilled nursing and being able to deliver the OASIS for the home health to the state of Michigan so the money can get back to those folks, because there's a lot of changing and moving parts for that industry right now. I mentioned earlier, it's a lot easier when one group talks to another group instead of asking us to talk to them for them. When it comes to an organization like Leading Age that has a membership already there, Mary mentioned POs and PHOs and different types of things like that. It's very helpful to partner with groups like that so we can help get stuff done faster, because there aren't a lot of us on this team. And there's a lot more work than we are all in this room even comprehending. Kind of all over the place.
One other thing along that line is a lot of those new areas that we go into aren't because we just are so creative and come up with these wonderful ideas. We get those from you folks. So again, and I've shared this with others, but those dumb ideas that you have, it's like, oh, they wouldn't want to hear about that. That's kind of a dumb idea. You have no idea how that may be sparking another thought, or even that idea in of itself that you may think is dumb may be incredible, that we can then partner with others as well. So it's really one of those, it's because again, we're that community service for you. We want to serve you on that and come up with those ideas and partner together. So it's our community together. So please, as you're thinking about, oh, you know what, maybe we could connect this way, or maybe this idea, we welcome those ideas, because that's where we can all grow together and come up with new and creative ideas too.
Yeah, one thing that we really try to focus on is meeting you where you're at. We have solutions that we've already built, but sometimes you get into your environment like, that solution doesn't quite fit for me. I need to do it this way. Can we do it that way? And we really pride ourselves on meeting you right where you're at, saying, how do we customize this to fit in your office or to fit your need? Not make you say, well, we have our solution, you have to fit it. That is not our philosophy at all. Our philosophy is we have solutions and we have knowledge here. How do we make the community work better? And that's always our approach when we work with customers.
Just going to note a couple relationships quick, because we try to anticipate as well. So Point Click Care is a vendor out there that's used in post-acute space a lot. Rather than going one-on-one, we've had conversations with Point Click Care, have a relationship now to build one interface into their hub platform to make it easier for organizations in that space to onboard. In the community mental health area, where we've got a number of CMHs around the state that are working with us, PCE Systems is a big player in that space, and so we've built connectivity. In fact, Washtenaw, over in that part of the state, has single sign-on from PCE Systems directly into Viper to pull that record back, as well as other things that we're doing with Jeff and his team over at PCE, because it's better to do it once than do it one time, kind of for everybody. So those are a couple as we're exploring moving into some of these areas that maybe we haven't been as heavily engaged in before. One of the ways we're trying to do that is figure out who the major technology players are and how can we kind of build stuff once that should lower the cost for all of you guys as well, because your vendor's not having to do it 15 times. They can just do it, once.
So we've got just a few minutes left here, and you all have been listening very attentively to the prepared questions. I want to give you all the opportunity to put us on the spot a little bit. I would like to ask a question of the room, and that is, what do you think that we're doing well? And what kind of feedback would you like us to have in terms of things that we could or should be doing better for you? That's really the point of our being together today, is to learn as much from you all, the community that we hope to serve, as we do deliver solutions. So Emily is going to come around with microphones. If anybody has a question, something that they would like to address to the panel. would you want?
Something really hard.
Something really hard for Chris or Mary would be.
All right, while we're making our way, I'll lob out one other question while we're finding our next, and that is Mary, I know that you're very excited. A few months ago, many of you may be aware that Great Lakes Health Connect made a significant commitment to the community of Flint in response to the water crisis. And that's something that we've been working actively on over the last couple of months. Mayor, would you be willing to just give us an update about where we're at and the status of our Flint project?
Sure. I'm happy to announce and introduce, actually, Katrina Corey, who's in the back of the room. She joined our team recently, and just last month, and she is getting up to speed very quickly. She's a Flint native. She lives in Flint. She's worked in Flint, and she has amazing relationships. Every time we go to a meeting together, they hug her. So I did a good job on finding her and hiring her, and now she can take the ball and run with it. We've already got relationships with the 3 hospitals there, and Greg Kavanaugh had been working that area prior to that and worked with the ACO. So we're going to be transitioning the relationships and making sure that Katrina can take that forward as we talk to the Community Foundation, the Greater Flint Health Coalition, the United Way, and all of the other social determinants of health. Because in addition to being able to get the information from the facilities, most critically, lab results, so that we know when these kids have had an elevated lab level. We want to make sure that they can get that back to the primary care, but also, no matter where those kids go, they would be able to be on the Viper tool. So they can see that lead level if they got it from Hurley and they happen to be McLaren Dock, or if they're going to a Genesis facility and they're in the GGC ACO. Now that's a lot of initials. So that we're passionate about providing those solutions, but we're also really intent on listening to them. And one of the things we learned just last week is we were sort of oriented towards the kiddos and thinking, okay, it's about the kids, it's about the pregnant women. They said, we're actually now really getting aware of and being more concerned about the older population as well. Because as lead has an impact on older folks, it's going to have an impact on their cognition, and they regard that as a vulnerable population. So we're going to be talking to internal med docs as well as peds and family practice and OB-GYNs. And Flint is all in on this. They're really appreciative of the health. I think that they're just coming off the wave of being overwhelmed. And now they're kind of going, okay, what's the next best step? What do we do now? And we're there to help them figure that out from the physical health and health information exchange point of view.
Let me throw in 2 cents too, because Flint is one of those things, and it was referenced this morning, I just want to tie it back again, that should be a lesson for all the communities. The stuff that we're doing there to figure out for kids that have these physical needs certainly, but then the behavioral things that happen with lead, poisoning and the other cognitive and other stuff that gets into the schools and the other environments. What you heard from Dr. Poland just a little bit ago is the exact same thing is happening for patients here. It's the stuff we have to do. The unfortunate thing about things like Flint is it's the reminder to a community is the what for. Why do we have to do it? It's when we run smack into one of those that it goes, that's why we have to do this stuff. That's why we need it. And we're hardwired as human beings to kind of run into the wall before we see it. So a lot of the things that we're doing there, kind of post-mortem, to say, okay, how do we put the right infrastructure in place so that we can take care of what we see today, and also understand what's the future public health model look like, so we're maybe not as dependent on some of the old things as we used to, so that these things don't slip by us, quite so easily. It's the exact same thing that we're trying to do here, absent kind of the specific what for that happened out there. So it's all really, tied together, and as those kids move, or those individuals beyond the kids move from Flint to West Michigan and start moving around as everybody is apt to do, the fact that it's all integrated into the same platform and the information can be shared is just going to make it that much better as they traverse and folks here that way as well.
Yeah, I'll piggyback that and just the question Brian asked about the skilled nursing and home health. The frail patient is lost as well. And so a lot of the different initiatives to help track those patients when they go to and from in an ambulance with a folder of information that may make it with them or not. Getting that information from that skilled nursing facility, from that home health group that says, all right, I'm going to go into their provider. It's just not hospital stuff. It's also doctor office stuff. It's also skilled nursing information. It's all in one place. It's not a holy grail anymore, which is great because it's actually practical usage and practical use cases. And Doug and the boss who's either on vacation or at the conference, he always says, we're not going to do it if there's no value to it. And the only way we truly know there's value to it is from here. We got perceptions. We have some experience, some social workers, and but I think honestly, when it comes down to the benefits of those patients, whether the peds, whether it's the frail patient that can't advocate, that can't go to the vet down in Battle Creek because the spouse can't get on their back. I mean, those are the things that really matter.
Last chance, questions?
Well, first of all, I love Great Lakes Health Connect. As far as the referral aspect of it, it's made my job so much easier. I'm just wondering, when it comes to Viper, are patients able to obtain their records that are entered into Viper, or do they have to go to each individual hospital or office that they've been to get those?
Yeah, we've just had a pretty deep review of our business associate agreements that we signed because we operate on behalf of the covered entities that give us the data, so we're their business associate. And the way, not just ours, but most in the industry have been written to this point, if a patient comes to a business associate or comes to us and says, I want to see the data that's in the exchange, we have to send them back to the covered entity because we don't have permission per the agreements today to make that data available. Now there's many reasons why, as things have evolved over the last 5 or 6 years, that maybe that doesn't make sense. Patients who maybe want to send data to their own personal health record so they can have the stuff there. Patients who maybe sign up for a particular trial and need their clinical information sent to the folks that are administering that trial, going back and talking to every 15 providers, you know, to build it. And some of that stuff doesn't make sense, but it is what it is. So we actually have a process underway right now to go back to our participants to see if we can't get them amended to say that if a patient comes and signs a consent that they want their data released in some way, that is something we'd be able to do on behalf of the participants rather than sending them back. I imagine we'll have some very interesting conversations with some of the compliance folks in that. But that's where it is. So, and I'll just touch on a couple other things related to patients in case it's a question for others. We still have not gone directly to the patients and tried to establish relationships with individual consumers themselves because we believe that does a couple things. I'll say I'll believe it does a couple things. One, it puts us in front of you who are caring for them. I don't know why a person would have to care that we exist. Frankly, our job is to enable the clinicians in the community to provide the type of experience we want every person to have relative to facilitating their health and wellness and care. And so whatever we can provide from a data, service, whatever standpoint that makes that better, that's what we want. So we don't have a personal health record. We're not going out and trying to approach those folks because I don't want to try and draw their eyes to me when they should be focusing their eyes on, you know, kind of all of you. However, as a conduit, as there are more of those PHRs that are unfolding, we may need to be a relay where we're sending the data through us from our participants, and so that's what we are keeping our eyes open for. That get all of what you were wanting to know? Okay.
Any last ones?
Someone had a question in the back.
may be naive or premature, but I'm struggling to learn what's going to be required in the new NAPRAs and the CPC Plus platforms for primary care. And one of the things they're talking about is risk stratification. And I can figure out how we might do that within our own EMR. There's some functionality there. I'm wondering if that's something that is on your horizon at all, or bigger than at the EMR level. Does that make sense to anybody?
Oh, yeah. So, I think from my standpoint, the details as to what all that means are equally blurry. But what I've tried to boil things down, even in this health information exchange world and where things were going, I don't know. Every time I put a year plan together, the only thing that's been 100% true is that I've been wrong at kind of where things ended up, because it's just hard to project and understand that stuff. But there are base principles that we know, regardless of what it specifically looks like, there are certain things that have to be in place. One of them is we're going to have to be able to get the data out of the EMRs and have it ready so that we can do measurements based on value and quality and those sorts of things. We also know, regardless of what the specific details are, that we're going to have to do that reporting with data that doesn't exist in my system. So if I have an EMR, when we're in an ACO relationship, we're in a clinically integrated network relationship, with the SIM, thing that's coming and all of that's all geared toward bringing folks that are on different systems and platforms together. There is no question that the quality measurement reporting we're going to have to do is going to have to be beyond what any particular electronic system has. Specifically what that is, we'll find out. So what I'm trying to focus us on is being able to do those two core things very well. Get the data out in a way that makes as much of it reportable as we possibly can, and do it in a way that as we bring data from multiple systems, that we can sit that data side by side with each other and do common sets of reporting across. I think if we do that, we'll have the base for whatever the specifics turn out to be. And I think that as the clinical community, the same is true for some of the other solutions we have, even the use of Viper. The way the clinical teams are being organized, the way the business is being done are changing so much. Technically, we tend to be very good at when there's a clear business, we can put technology underneath it and make it hum. When there's blurry business and we put technology at it, we just make a really technically blurry thing. We can't solve the blurriness there. So I think with MacroMIP, some of these other sorts of models, payment models that are coming out, we're kind of hoping that the business environment starts to crystallize a little bit, which gives us better understanding of exactly how we need to engage it. But like I said, regardless, getting the data out, normalizing it in a way that we can sit it side by side and do reporting is something that we're focused on.